Thank you for being here. Can we start off with discussing what is the potential for using outcome-based commissioning in the field of home adaptations and fall prevention?
So let's just take that question apart, because I would argue that the falls prevention is one of the outcomes that you gain if you adapt the home. And so therefore there is huge potential for outcome-based commissioning of these activities if people are very sharp about what the outcomes are that they're going to measure. And for home adaptations, we've got international evidence that you can mark out a number of outcomes that I think could be measurable by commissioners. And the headline one, which is very costly both to the health service and social services, is falls prevention. There's also a measurable impact on people's mental health and well-being. And I think that should be of increasing interest to people because of all the knock-on effects if you don't tackle mental health and well-being. And the other important outcome is enabling people to undertake what we call the activities of daily living. And that again is very interconnected with mental health. If you can wash, you can dress, you can cook, and you can generally look after yourself with less input from carers. That's a very important outcome for human beings in terms of their dignity, their sense of self-respect. So there's certainly potential.
So you already touched on this a little bit, but if we put yourself in the shoes of a commissioner, what are the sources of value and financial value for a commissioner?
I think that home adaptations and falls prevention are actually a perfect area for joint commissioning across health and care. I think it could be quite problematic if we only have outcomes-based commissioning solely for social care. And that's primarily because with the squeeze on expenditure on social care by local authorities, they're only actually financially assisting a very small proportion of the older population. Between sort of 1 and 5% seems to be the range at the moment. Whereas the health service, free at point of delivery, is there for the majority of the older population. And many of the interventions that home adaptations undertake result in improvements for health services, because falls are one of the major reasons, falls and fractures are one of the main reasons that older people are admitted to hospital for an unplanned intervention. So any reduction there will be a saving. But also you then got down the line, if you prevent that fall, you save the NHS money. But because most people who've had a fall will then go on to residential care, then it becomes a cost to social services. There is a knock-on effect. So you have to put all the parties together and say, can we enable safe, independent living at home for longer as a way of saving money to both parties? So pooled budgets would be ideal, shared outcomes would be ideal, and then home adaptations fits very well into that model.
What are the challenges to make it happen and any solutions to tackle the challenge?
Okay, a very big, well, as well as the integration, that's a really big challenge. But a very big challenge is the data collection and attribution of causality. And so if you reduce risk by a home adaptation, you reduce the risk of a fall. Actually then recording, measuring the timescales over which that reduced risk extends the time that a person doesn't have a fall, that can be quite challenging to measure because other things might come into play. So a person might have a health condition that might, if I take cold or flu and they feel quite weak and they go down the stairs awkwardly, even if you put in the grab rail, the risk is reduced. Other factors in that person's life might mean that they still have a fall. So the attribution of that long-term reduction in the fall can be slightly problematic. I think it will take some fairly sophisticated work by academics such as yourself to help everybody to pick this apart and actually quantify the gain.
Okay, good challenge to have. And what is the practice and evidence around fall preventions and home adaptation at the moment?
Well, the evidence around the impact of home adaptations, we've had a major international evidence review which resulted in the report Better Outcomes, Lower Costs that the Department for Work and Pensions paid for, probably coming up to a decade ago now. And that all the outcomes that I've highlighted this morning around falls, mental health, daily living, that very much came out of what were the outcomes in all this international literature review. And that also quantified the areas of saving. Now, because that was quite out of date, we've been working with the Centre for Ageing Better, who commissioned the University of the West of England to undertake a fresh, up-to-date international literature survey. So that's coming out in the summer, and that will give us, again, an overview of the outcomes that result from quantified, on the whole, outcomes and quantified savings from undertaking home adaptations. Your question was, what's the current practice? I am not aware of any great models that I could point anyone to of outcome-based commissioning of home adaptations. The system as it stands is you have a specific pot of funding for home adaptations for low-income people who, if they meet certain criteria, will get it. So it's not actually commissioned on an outcome basis. It's very much administered on an outputs basis. And I think I'm looking to some evaluation that's underway in Wigan at the moment, where they introduced a new non-means tested fast track adaptation funding to get patients out of hospitals faster. And I think that was going to be a very interesting piece of work that should be finished during the summer. So that's a very specific little pilot, but it certainly doesn't translate into outcomes commissioning. So that's a challenge for the future.